Thanks everyone for joining us. My name is Jessica D'Angelo. I'm the microbiology supervisor at Palomar Health in Southern California. I'm going to be introducing today's speaker and panelists. So welcome to the ASM webinar. This is Core Lab Concepts, Considerations and Lessons for Microbiology Lab Consolidation. This webinar is brought to you by ASM's Clinical Microbiology Mentoring Subcommittee. Please visit ASM website to browse resources provided by the subcommittee and get in touch with a mentor if you're interested. Okay, we're going to start by introducing our speaker, Dr. Rich Davis, and then after his presentation, we'll introduce the panel. Dr. Rich Davis received an undergrad degree in medical lab science and worked as a bench laboratory technologist before returning to graduate school. He received a PhD from the University of Iowa, studying Leishman, help me out, Rich.
Leishmaniasis.
Leishmaniasis. I looked this up and I still butchered it. I am so sorry. And then completed a clinical micro fellowship at the University of Utah Arup Laboratories. He currently directs the regional Washington, Montana microbiology core laboratory at Providence Sacred Heart Medical Center and Children's Hospital in Spokane, Washington. He also leads the Providence Healthcare Systems Microbiology Molecular Technical Working Group. I'm now going to turn over the mic to Dr. Rich Davis.
I already unmuted to talk about leishmaniasis, which I love to do. Thank you very much to the organizers. Happy to be here for this presentation today. So let's just jump right in. I think everyone is interested to talk about how to make a core lab. So all right. Nothing to disclose that's relevant to today's topic. The three learning objectives we'll be going through today in the presentation and panel discussion is describing major and minor challenges associated with test workflow changes that are inherent to lab consolidation. I'm going to recommend some methods of effective communication during the planning and implementation phases of that consolidation, and then call out a few specific areas and processes like culture setups or lab education that might require some atypical or novel solutions because you've consolidated. So to start with, how do you consolidate a group of microbiology laboratories? As the saying goes, the same way that you eat a whale, and the saying is that you do it just one bite at a time. If anyone recognizes this illustration and poem, this is from a book of children's poems that I grew up with called Where the Sidewalk Ends, where tiny Melinda May eats a whale. She's much too small, but it doesn't bother her. She takes little bites and chews very slow, just like a good girl should. And in 89 years, she eats that whale because she said she would. So obviously we don't have 89 years to consolidate a microbiology laboratory, but it can be done. And to push this metaphor just a little bit further, in addition to the how do you eat a whale one bite at a time and the way it relates to microlab consolidation, a few other things that I thought of. You do it when you realize it's the best or the only option. You got to do it very carefully after researching the best way to do it, ideally doing it as a group, and you're probably going to make a mess, even though you try hard not to, but you really got to do it as hard and commit to it as hard as you can, and then ideally do it with a plan, which is what I'm going to be kind of talking about today. So thinking back to our experience and the steps we went through, I feel like these really fit into 5 major phases in a timeline. The conception phase, preparation for an executive and formal proposal, when you've committed and before you go live, actually going live with your core lab, and then final phases of going live, and then ongoing from here on out. So to walk you through what I'll be showing today is we'll talk about these 5 phases. And then I've got lists and bullet points under each phase. So you'll be seeing the same boxes and this color scheme throughout the presentation. And I'll just tell you now at the front that at the end, there'll be a slide that has all of these different phases and all of the different bullet points summarized in one single location, if that's a helpful resource for you to see it all in one spot. But this will help us walk through the different points that I've thought of, and hopefully we'll generate some good discussion later where we hear about from our panelists about other ways that you can potentially do this. So let's start with the conception or this discovery phase. So obviously the first thing you're going to need to do is plan and decide where your core lab is going to go. So for us, that's here at my institution at Providence Sacred Heart Medical Center. We're in Eastern Spokane, Washington, and it kind of made a lot of sense from the get-go, and it probably will make sense in your institutions as well. We're the largest hospital and the largest laboratory in our region. We were also very supported by really proactive regional lab executive and medical leaders. who really took this idea, really championed it in the places where it needed to happen. And interestingly, in our 7-state Providence Healthcare Network, we were the only region that didn't have a micro core lab at the start of this. And there's really good reasons for that. We were very, very spread out across these 2 states, and there were some actual physical barriers in the sense of these mountain ranges that go between eastern and western Washington that always have snow and pass closures, and then between Washington and Montana as well. But it made sense for our lab, not just because of the size. We also are the largest, we had the largest test menu. We were a laboratory that supported AFB and fungal labs. We were the only laboratory in our region with a MALDI-TOF, and we had a good labor pool, both because of the urban Spokane environment and because of our in-house School of Medical Laboratory Science. And we're going to hear from Lorianne, one of the leader of that education program, later on in our panel. So the biggest factor, though, in addition to all of these that led to our centralization here, was that this was the location we'd stood up for high throughput pre-surgery COVID-19 PCR testing during the pandemic. So we already had dedicated courier runs and drops happening every single day. So it was logical to think, can we add microbiology testing onto that? So a key feature of our potential core lab model is that we definitely wanted only to have pre-plated and incubated cultures. We knew just looking at the amount of time and cost that this was the only way to make it work over these regions. And by doing this pre-plated incubated approach, we could, and then sending them in these warmed incubator type totes, this is something that we'd seen happen and work in smaller locations, both within Providence and in other institutions. And this would also have the benefit of letting the spoke labs retain their critical on-site micro capability. So first and foremost, they would have their blood culture instruments still. So we know that you want to get blood bottles into those instruments within 4 to 6 hours of collection. So that would still happen instead of being sent once per day across the state. They would have their rapid molecular Verogen or biofire tests. They'd have gram stain reading, and of course, the culture plating and incubating capacity as well. So our first thing is we needed to prove to ourselves that this was going to work by validating this incubated tote concept. So we use these commercially available lithium battery hand warmers and insulated, we call them totes. They're essentially coolers. We call them totes because they are not cool, they're warm. So the first thing we did was experimentally test after defining these parameters of how many warmers you needed, on what settings, et cetera, testing to make sure that they support acceptable clinical performance. So we did that by comparing side-by-side temporary in-tote incubation followed by in-lab incubation compared to directly plated and directly incubated in-lab plates. And we tried different lengths of time. 7 hours is about the maximum length of time for a normal courier drop between site to site, but we also pushed that for longer in case of delays. We also tested normal room temperatures and also with our walk-in refrigerator, cold temperatures to model some of those winter conditions we face. And the conclusion was that this worked very well in our hands. Testing close to 200 clinical samples, we saw 98% exact agreement where both plates showed exactly the same number and type and quantity of organisms. And if you consider clinically acceptable agreement, where there was nothing missing from those that went into the tote, there's only one culture, so almost 100%, that showed it was missing a rare organism that didn't grow when it was in the tote. So we felt that this really showed the proof of concept, this really can work well in our hands. The next thing, and this is a very colorful slide, but the highest clinical concern we heard during the conception phase was those delay to culture results. So trying to think of how to demonstrate that the potential impact, this was what I came up with to kind of model this. And essentially what this is trying to show is the percentage of cultures based on the time of day that they arrive and get set up and plated at a spoke site. What time are they going to actually have a bench technologist read that plate and chart a result into Epic or into the patient's chart for the providers to see? So starting here at the top, this is essentially breaking down the specimens that arrive to a laboratory over the course of 24 hours. So between the hours of midnight and 1 a.m. is the 0 hour. And you can see we see about 3% or 2.7% of specimens were arriving to this laboratory. This is real data during that time. So let's walking through that time of day. Those cultures get set up. They're incubating and cooking. Well, they're going to be too young to be looked at on that first day shift. Potentially, a laboratory could go in and provide a request, look at them and say, yes, there's something growing, maybe do a gram stain, but really nothing definitive. And so these plates are going to keep cooking, keep incubating overnight, and really not be looked at until the very next day shift, first thing in the morning. Then when you look at the afternoon samples, so the samples that start to arrive between 2 p.m. all the way through midnight, These are samples that really are going to be too young to be looked at first thing the next day on the day shift. And really only a small portion of them are going to reach that 18-hour incubation time only later on in that shift. So a lot of these are really going to wait for another day anyway. When we compare that to a model of when we have a core laboratory incubated in transit totes and then day shift and evening shift. So for the first part of the day, those samples that arrive between midnight and like around 1 p.m., same thing happens. They still incubate in laboratory. They incubate in transit as they get to the core laboratory, and then they're ready to be looked at right first thing in the morning. But then the real benefit is those afternoon specimens. Not only are these incubating in laboratory in transit, and then will continue to incubate in the core laboratory, but thanks to our evening shift, now we have the opportunity to look at them and actually chart a result for that. It's not necessarily going to be looked at 11 p.m. or midnight by a provider, but it's going to be ready first thing the next day. So doing the side-by-side comparison, and granted, this is a very idealized setting, it doesn't always go as smoothly as this, but this really helped us show that, hey, not only is there not necessarily going to be an inherent degradation of service, but there's actually some opportunities for clinical improvements over the status quo. Remember, with our MALDI-TOF, we're thinking that a lot of times these first preliminary result is actually a final conclusive organism identification, for example, and the susceptibility results that could be set up first day for early next day reading. So actually improvements in some contexts. And really, this also helped us plan out and think of when the courier should be picking things up, when they could be dropping us off. So if this is a helpful tool in planning in your sites, this is something I wanted to show you that we did. And then the last thing in the conception phase I wanted to address is the impact to education. Our labs not only support clinical services and are there going to be, and consolidation can impact your workforce, but also has serious impacts to lab education and training programs. So we all know that our nation is facing MLS and MLT staffing crises. This slide and this table in specific were created by Lorianne and her education team to kind of demonstrate how the MLS MLT workforce compares to registered nurses in the United States. So you can see the total number of active individuals and projected vacancies. Our vacancy rates are, relatively similar between these two job types. But when you compare the annual number of graduates in registered nursing programs versus MLS MLT programs and the graduates per vacancies, we're really seeing a huge shortage where there's not nearly enough graduates of MLS and MLT programs compared to those vacancies. Another big challenge is that microbiology, and it's worth noting blood bank sites, have real challenges in finding clinical rotation sites for those programs. And in fact, during a 2020 survey by ASCP, 55% of university-based programs had difficulty finding clinical microbiology rotation sites, and that was only 35% for blood bank. So this is a real important component, not for training microbiologists, but for training anyone who wants an MLT or MLS certification. So it's hard to find those sites, and it's hard to stand up those clinical micro rotation sites. Simulating those rotations can be very expensive and time consuming. You don't have access to clinical specimens that come into our labs every day, and they may not provide experience with those big ticket instrumentations like our blood culture instruments, molecular tests, and MALDI tests that really drive a lot of the work that we do in these large micro labs. So our go live in our region of our Washington, Montana Micro Core Lab had really major unanticipated impacts to regional education programs, where suddenly 7 different clinical sites that previously supported rotations for 10 different education programs across our region, suddenly those were all consolidated down into one single location, and we really could only support a small fraction of those rotations and none for a lot of these external programs. So unfortunately, a lot of these simply just went away. And I'm including this in the conception phase because it is a thing you really should consider early on. And I'll call out as a major failure, we did not loop in education early enough in this process. And in fact, a lot of decisions had been made prior to us knowing that this was going to happen, and we didn't have enough lead time to work through any other alternative thoughts or programs or methods we could have had. And this was a real unfortunate and a blow to our regional microbiology and laboratory service training opportunities. But that completes the different phases that I consider during the conception and discovery phase. So once you've proven to yourself that you can do this, you now have to prove it to the executives, the administrators, and the finance folks that you can do this, which takes us to this next aspect, the preparation for an executive proposal. My first tip during this phase is that ideally you want to identify a dedicated project manager who can help consolidate this and really take this to fruition. And ideally, this is a project manager who has laboratory subject matter expertise, someone ideally in leadership, someone with LAS expertise, we were fortunate enough to have a manager of one of our sending, or we call them spoke sites, be the project manager for this. And really, she was instrumental for keeping us on track, pulling all of this information together into one spot and supporting the creation of our business plan. That formal business plan we called a pro forma, and this is what you really need to demonstrate and show that your consolidation makes sense. So this is going to include financial evaluations and comparison, forecasts and goals, calling out clinical and financial risks and maybe mitigation plans. And it's what's going to be presented to administration, finance, and medical executives. I'm only listing some of the components that a pro forma might need, like test volumes, productivity metrics like worked hours per unit of service. You're going to need to establish goals, which can be uncomfortable because you have to forecast the future and how good you're going to be when all of this comes to fruition, and calling out predictions, timelines, and impacts to maybe contracted send out volumes, things like that. So some other considerations that are going to support the creation of that business plan are essentially evaluating potential impact and mitigation of that impact to your staffing. This is going to have, consolidation always has big impacts to staff. And so you're going to need to work and talk with human resources, your HR team, to think through and talk about employment requirements. I've listed a few questions you could consider raising with your HR teams, like how do job descriptions expect to change at the different sites? Are there union representation requirements that are going to change the timing or the scope of how jobs can be modified? And if you want to keep someone, are there resources like bonuses that you can encourage someone who's only really wants to work in micro, but you want to keep them on, that you can maybe employ or roll out at different sites? You're also going to need to make decisions around workflows that are going to impact finances, like equipment, what can stay and what needs to go where, supplies and consumables, who's going to purchase what. I'll cut over for another tip from our experience. We decided that each site was going to be in charge of maintaining their own supply. We do cultures, so of their culture stock, collection equipment, et cetera. And actually, this ended up helping us in an unexpected way. We mostly did it for financial clarity, but during supply shortages, we've had cases where we could move things across the state, share alike between the laboratories that really helped fill gaps that unexpectedly cropped up. Compared to if we were receiving everything and then sending everything out to those sites, we might have been a little bit more trouble and had a little bit more time trouble filling those supply gaps. Some other things that we didn't think of right off the top is you'll need to consider proficiency testing, what needs to stay at spoke sites and what can go away. So, cost savings. And then thinking about how you're going to bill and charge for the tests you're reporting and the labor that you're doing. So down here below are some other questions you could raise with your billing team, how you're going to bill the tests. Are you going to bill the patients all directly? Are you going to bill back to the sites that are sending you your specimens, et cetera? And if there's like labor at both sites, how do you split up that productivity and that labor, et cetera? And then the last tip and the last recommendation in the executive proposal phase is make any requests for IT support, LAS resources, et cetera, as early as you can. This kind of project is very large scale and might need a lot of resources. And those kind of things might need substantial lead time and resources to make sure that you are going to hit your desired go live period when you are able. So let's say that all of this goes as well as you hope. You now have sign off from your executives, you're committed, and now you need to actually plan to go live. So now we're going to talk through some points and considerations during this phase. Arguably one of the busiest and wildest phases. So the first thing you're going to do is set a date. The date of your go live not just going to dictate all of the time you need to have this ready for, but it's also going to dictate when you need to start communicating to all the people who are going to be impacted. So I would definitely recommend having dedicated communication that would go to laboratory leaders and staff, how it's going to impact them, the communications that go to clinical teams and administration, and what those look like might be a little bit different. And you should also commit to a cadence of communications, 6 months and then 2 months and then 2 weeks, something along those lines. Another tip from our learned experience, if there's any details or communications that are going to go out that might impact aspects of people's employment, you'll definitely want to loop in your HR team early. We were having some of our communication drafts reviewed by HR. It took longer than we expected, but so we didn't meet our timeline for communication, but it was really critical that we have that review so that we were communicating the most accurate and up-to-date information before it went out wide to this very large group. You're going to want to test your LAS routing, so making sure stuff that gets ordered at one site populates in your work lists at other sites. You want to make sure that you can transfer things between sites appropriately, et cetera, and make sure all the reporting continues to happen as well as it needs to. Ideally, if you can, I would recommend requesting a dedicated analyst who's assigned to all of this LAS work. ideally at the go live, but also if they can participate in planned meetings, all the better. You're going to need to create and share any formal procedures, job aids, or materials that are going to guide some of this work. An interesting thing that we hadn't really thought of initially was, our procedures, our SOPs that we use in the laboratory, they follow really regulated approval processes. So now you have a procedure that's owned by multiple sites or overseen or impacting multiple sites. Well, who signs off on that? And our answer to that question was, well, we really kind of divided down the scope of oversight. Who owns each part of it, the setup, the transferring, et cetera, and then making sure that each appropriate sign off by operational and clinical laboratory leaders is done appropriately. But of course, creating all of these things as a group, making sure everyone has access to those at the same time. So some of your SOPs and job aids might include, LAS transfer workflows, how that happens, how you add on a send out tests to different sites, and then how you're going to handle and package specimens or cultures. So I'm showing a few examples over here on the right-hand side of our SOPs and job aids and checklists. And we also even did a video for our lab assistants and techs of how to package up our totes, right? How to turn on the batteries and put in the basket and put in the racks and boxes, et cetera. So you have all of these things. You're also going to want to make plans and make those resources for how you're going to document all of this is happening and how you're going to communicate lab to lab. So another tip is going to segue into my next slide is if you can create a single online location with all the links and resources and QC logs and everything you want all in one spot. So I'm showing you now what ours looks like. This is the Microsoft product SharePoint. It's a website or landing page building resource that was recommended and built by our first project manager, which has been really phenomenal. We use this literally every single day, and we have since going live a few years ago. But just to orient you to a few of the different aspects of our SharePoint site, we have an issue entry log. So if we ever have issues with gram stain discrepancies, if we ever have totes that come in packed inappropriately or missing some components, our bench techs go in and enter an issue here with this. This is a clickable tab, and that populates an automated issue tracker, which is found here. It also populates an automatic email that goes to the leaders of those laboratories. You can have resources like test directories, courier pickup times, et cetera. Down here, we have QC logs where we enter the daily QC that comes with every one of our totes. And then below, we have links to our SOPs, training materials, and other documents that apply to the work that we're doing. So I mentioned QC, and because it's kind of an unusual process that we use at our core lab model at the scale that we do, we really wanted to have processes in place that made us confident about the quality control of these transported warmer totes. So in addition to the totes themselves and containing the warmers, the cultures, a printed out packing list, and then a checklist of making sure that all the appropriate steps were followed, every single one of our totes that comes in every single morning from across our region comes with a thermometer and a freshly plated QC bug. This is a plate that is freshly struck out right before packing with an ATCC strain of Haemophilus influenza or Neisseria gonorrhea. And by doing this and monitoring this on every tote every single day, if there are ever failures where temperature is out of our acceptable range, if a QC bug fails to grow from one of those plates, well, that's something that we can automatically flag and follow up with. And having these in place, again, for every tote every single day really makes us confident that we know the conditions within that tote from that site from that day were adequate to support growth, adequate to support the continuing incubation of plates that had already been struck out, and really make us feel confident that if something did go wrong, we'd be able to catch it in a timely manner. So with all of that in place, you've done all the preparation, the anxiety is building, but now you actually have to go live. So a few considerations during that really stressful period. My first tip for this going live phase is, if it's possible, plan to do a phased go live. So doing it in different phases if you can. A lot of benefits to that approach that lets you vet or tweak some of the processes you did during the planning phase, making sure your LAS transferring works, that your SOPs and job aids are acceptable, that you're communicating well lab to lab, and that your staff are ready. And if they have any things that they need to call out, a lot of great recommendations came from the lab staff themselves, testing all of these processes out. So in our region, our goal was to do a 3-phased go live. And while some of these benefits were definitely realized by us, the biggest reason we did a 3-phase go live was dedicated by our LAS functionality. So at the start of this, Sacred Heart here in the Gold Star, and then phases 1 and 2, Northern and Western Washington, we were all using the LAS Cerner. Between phases 2 and 3, all of our sites had to transfer to Epic Beaker. And then only after that, we were able to bring on our phase 3 sites who were actually using Epic Beaker, but a different instance. So the phases were dictated by LAS, but we learned a lot from them and we benefited from that approach. So something recommendable if you can. When you go live, you're definitely going to want to schedule your go live command center type meetings. So for the first couple of weeks, this was a every morning call to talk through how things went, how things arrived, any issues that we'd seen. We transitioned that call to one that after a couple of weeks to just calling once a week. And to this day, we still have a call every 2 weeks where we go through the issue log that I showed, talk about courier issues or any other challenges that our sites are facing. You're going to want to have an interlab communication plan. Again, we're saying communicate a lot. Specifically, what I mean is if a provider needs to talk to the laboratory or someone else needs to get a hold of a laboratory to add on testing, request susceptibility testing, et cetera, how are they going to get that information relayed to the core lab? So a tip is, if you can, have an automated workflow where providers can call one singular number, and then with a phone tree, meaning like automatically, push 1 to talk to the core lab, push 2 to talk to your in-house laboratory, the call gets routed the right spot. The laboratories can communicate between each other if things go awry. But this is not what we had live at our go live, and we transitioned afterwards, and it has been a much more popular and a lot more effective communication system. So the last thing under the go live phase is evaluating how you did. And I think doing initial evaluations is something that really benefited us. And actually something we saw that was interesting during our phased rollout. So our phase 1, this was a northern rural access hospital that had its own small microbiology laboratory. And our plan was to start sending our pre-plated cultures in November of that year. But because of an unrelated staffing crisis, they actually needed to start sending specimens only. They couldn't even plate and keep them in-house starting in October that year. And ultimately what that meant is we actually had a natural experiment of what does it look like when you read in-house versus when you send specimen, which is a more traditional microlab consolidation model, versus sending pre-plated cultures to a laboratory with an evening shift. And so the metric you're seeing here in these histograms is the number of hours to when you had your first charted culture result. So with the in-house reading, we saw this really expected biphasic cultures that were old enough to be read on day 1 got a read. Cultures that needed to wait for additional incubation waited till the next day. And then when they were arriving as specimens, well, they did have to wait that first day, but thanks to the evening shift reading, we got most of them read by 36 hours. But the real win was with the pre-plated cultures. Suddenly, 94% of all of these cultures were having their first charted culture result documented in the chart within 36 hours of that specimen arriving to that sending site, which is really great and really, I think, was a good proof of concept. Similarly, we did a similar evaluation for one of our phase 2 hospitals. This was a laboratory that had the practice of that less than 18-hour preliminary reporting, essentially looking and saying growth or no growth. So in looking at the overall average numbers, yes, there was a pushback of our average reporting time to where it was later on, it was greater than 24 hours. But if you look at the value of the kind of results that were potentially reportable at less than 18 hours versus those that were going out when the cultures had incubated for long enough, and again, we have that MALDI-TOF final identification in many of those cases, we really feel that even though it's later on than they were previously reporting, the value of that data supported our pre-plating, incubated, and core lab reading model. So you've gone live, you got through it, you survived, congratulations. And then of course you go into the final phases of your go live and any ongoing work, because really this work never does stop. So one thing to recommend is establishing ongoing clinical meetings as well as operational meetings. Here we established what we called the Microbiology Clinical Steering Committee meeting series with infectious disease, pharmacy, infection prevention from all the different sites who were impacted by our core laboratory. And I got to say, at Go Live, this was a very challenging meeting series. I always felt like I was in the hot seat to review issues that we had seen, that cop to when things were not going as well as we hoped, take complaints, and I'd propose plans and ideals for progress. And it was really tough. But I got to say that since then, this has become a real major win for our region and for our system even. This Core Lab meeting series has become a source for stewardship conversation, standardization, and getting good clinical support for things like antibiotic stewardship goals, CAUTI goals, blood culture contamination, and a lot of others that I really don't even have time to go through. So that open and frequent two-way communication, it can be stressful. It's not really fun to be on the firing squad, but it absolutely was a huge win and definitely helped bring people around to the benefits of our core lab approach. The last thing I want to mention on before wrapping this up is rethinking education. Again, education was a major impactful part of our core lab consolidation. And so in the context of all of these traditional clinical microbiology rotations going away, thinking about what kind of components of that rotation are potentially something we could think about differently. So when you think about the questions that go into a clinical micro rotation, is you got to think about how are you going to standardize a rotation experience if you don't have a traditional micro lab or staff on site? Are there ways to simulate plate workup scenarios in a spoke lab versus a core lab setting? And then if different programs have different time requirements for their training, how do you make that work? All of these mean it's going to be quite a bit different than a traditional in-program training approach. This is a picture from our School of Medical Laboratory Science. But ultimately, there might be more options than it might initially appear. So in our model, we have very active components of training that are important for micro rotation at our spoke sites. There's gram staining, there's plate setup, blood culture instrumentation, and routine molecular panel testing still happen, and those are still critical components of microbiology clinical rotations. And then there might be other options for a simulated plate workup in a limited spoke setting. So potentially you could set samples in duplicates, send one to the core lab and maintain one on site. You can keep benchtop biochemical tests in-house, maybe not a MALDI or a molecular approach, but you could have some of that stench testing. And since you don't need clinical reporting, only mentoring, you don't need competency to report things out. And you could even have like choose your own adventure style simulated workup modules. So there might be more options available than might initially appear, and that could continue to support clinical micro education in your areas. So putting it all together, and I'm just going to land here for a minute, not really talk through any of these 5 different phases, just to show that this really was a lot went into the planning and the various phases of our go live approach. And too many people to thank that really contributed to all of these. And when you look back and you see it all in one slide, it looks very clean cut and very smooth. So in the spirit of transparency from my very last slide, I just want to show a few things that didn't go as well as we hoped, and continues to be a little bit of a challenge. We still have unpredictable weather and courier delays. This is a picture of Snoqualmie Pass. We had our first blizzard this week that actually led to our couriers being a little delayed because of a jackknife semi-truck. So it's making me anxious for the winter. It's this thing we still deal with every single winter. We're seeing attrition of that micro expertise across our region. These workflows can be very complicated and unique for lab assistants and laboratory generalists to deal with. Here at the core lab, we're very fortunate to have a constant influx of new staff and students from the MLS school, which we love and are so grateful for, but that's a lot to always be asking your bench techs to train folks in addition to doing their work. And then I'll also just mention in the middle of phases 2 and 3, not only did we have to go with a LAS changeover, we also were forced because of system contracts to convert from our Phoenix AST instrument to a Vitek susceptibility instrument on the same date. So don't recommend doing that if you can avoid it any way possible. The core lab was work enough. But I got to say that some things went even better than we hoped. Some of the clinicians who are our biggest skeptics, when they saw some of the positive outcomes to this core lab model compared to like sending out maybe to a reference laboratory, they were really grateful and in some cases became some of our biggest champions. And like I said, leading to some really major clinical improvements. And I will say even in the laboratory, we've really become a truly collaborative regional microservice line. I know these people so much better now. We talk all the time, and it really has led to some extremely positive changes, even though things look different now than they did a few years ago. Final acknowledgement slide. Too many people, like I said, to acknowledge, but I do want to call out in particular our regional executive director, David Jansen, and Dr. Kirsten O, our clinical lab director, regional director, who really championed all of this. Our project managers, Liz and Sam. Here at Sacred Heart, Jennifer is our supervisor, and you have our technical specialist and lab assistant lead, and then all of the bench folks who are pictured down here below, the current and past members. Our Sacred Heart leadership, and then all of the leaders across the different spoke sites in our laboratory that really make all of this work. Courier team who does this every single day, and then those clinical steering meetings, folks who really help drive some of these improvements. Down here is a Sacred Heart at different times of the year, getting to the holidays. But I apologize for going over my time. I hope that that prompted a few ideas from the attendees, and that will prompt some really good conversation from our panelists. Thanks very much, and that's it for me.
Thank you so much, Rich. That was really awesome. So thorough. I feel like you covered everything. You gave everyone a lot to think about if they're going into a consolidation or it's on the horizon. So now we're going to move into our panel discussion. Today we're joined by Dr. Kevin Albee, an assistant professor and associate director of clinical microlaboratory at the University of North Carolina, Julie Kennicott, the LIS technical specialist coordinator at the Mayo Clinic, and Lorianne Mullinex, the director of clinical education at Providence Sacred Heart Medical Center and Children's Hospital. And our chat is open, so if anyone has a question, please drop it in there. I can start us out. I'm just curious if there was any opportunities to standardize instrumentation with the consolidation, like was one lab using, was one lab a BD lab and one was a Vitek, and now you have the opportunity to kind of get maybe a better pricing, more standardization. I don't know if you mentioned that.
Yeah, I didn't touch on that too much. Certainly, when you think about susceptibility testing, some of that just went away. So suddenly, if there were differences in the susceptibility testing platforms and use, they no longer needed those anymore. We still have differences in, like, for example, some labs use Veregene in our system and some use BioFire. And so across our region, we have different approaches, and sometimes our techs like one more than the other when they're trying to confirm, blood culture PCR results, et cetera. But I will say that a lot of the financial pro forma business case work of this did relate a lot to contracts. I mentioned that we were kind of forced against our will to convert from a BD Phoenix to the Vitek, and that was due to not just regional but system-wide Providence contracts. So, but definitely there's opportunities to consolidate and streamline and potentially standardize when you think about consolidating, because you have to decide what needs to stay at every single site, and if there's better pricing opportunities, you obviously want to explore those whenever possible.
Thank you. Thanks, Rich. Does anyone on the panel have any comments? Any additional comments to that question?
I was just going to say that I really liked your comment, Richard, about get a project manager. I've found that there's so much to keep track of. There's so much communication. There's so many meetings that you have to set up when you're moving labs or consolidating labs, that having a dedicated person to handle those tasks really makes the whole thing go much, much easier, much more smooth.
Hi, this is Lorianne. Just from the perspective of the lab medicine education, and so I am a director of an MLS program at Sacred Heart. We're a hospital-based program, but because there were 9 other programs that were impacted by this, there was a lot of collaboration, and there had to be a lot of willingness on my part, even though, I didn't get a chance to be brought in on it, to say, hey, fellow educators, it's going to be a little rough, and I'm sorry this is getting sprung on you, but these are the reasons why, and what can we do to collaborate? So really having that heart for collaboration and being willing to listen when individuals are not in support, when they are really concerned, when they're feeling like they're being heard, it makes it a lot easier to come together and find solutions. And I'd really like to say that there was a lot of school mascots and whatnot listed on that slide that Rich showed, but most of the programs that we had to do real close collaboration with were willing to think about things differently. So really thinking outside the box from that perspective, which this whole process is thinking outside the box. How many other consolidation is happening with pre-plating specimens, right? So I think that was something that we needed to do that because of our topography of the areas we were crossing. But I think it's real genius, right? And I can say that because I wasn't the one who decided. It was really smart on their part to really think, how do we do this differently in a way that maybe most people aren't doing it? Because I think it's added a lot of value.
Awesome. Thanks, Lorianne. I'm also thinking about those heated totes. I'm also a central micro lab. I'm like, wow, that is really awesome. Very creative. So we have a question in the chat from Jeffrey. He says, was the quality Was the quality of work in terms of accuracy of results maintained or improved post-consolidation?
That's a great question. Ultimately, in addition, I showed the data from our in-lab validation when, in our own hands, how we took, close to 200 clinical samples, plated them in duplicate. One went into the tote for an amount of time. In addition, before any of our sending sites started sending actual patient specimens, we had them do similar work where they would set up plates in duplicate, keep one on hand, plate, send one, et cetera. Not as a high volume, but during that sort of clinical testing approach, when you're actually doing the transport, we never saw any differences. Things were only in many cases actually exactly the same. A few more instances where what grew in the totes wasn't like a contaminant, but just when you have rare Staph aureus on a plate or rare GNR, that it tends to grow. It actually grew on one versus the other. But that doesn't really answer the question, right? Because the answer is like, overall, have things been more accurate or have things gone better? I'm a huge believer that the MALDI-TOF compared to like a biochemical identification card that every other site in our region we're using, I think that in that context, for that piece of technology, things are more reliably accurate. So that's been great. I'll also say qualitatively, there have been a lot of instances where anecdotes from our clinician partners have said, like, this is results we weren't always getting when they would go out to another location. They would either get more generalized results, go to a reference laboratory, they weren't satisfied with the turnaround time. So I would say in that sense, the quality of the work and accuracy, it has been maintained. It's the thing we think about more than anything else. But unfortunately, it's not something we will ever have the fullest and most accurate answer to, because it is what it is, and we are going to keep doing the best we can to make sure that it is as accurate as it can be. If that answered the question.
Yeah, I wanted to see. Oh, sorry.
So as I say, I can go ahead and jump in and kind of, with another experience related to this. And so we are still at UNC, a kind of a hybrid system where we have some consolidation and a lot of not consolidation. But recently we had a hospital that's about 30 miles away from the main campus that had their own kind of in-house micro. We transitioned to having their micro come here to the main laboratory. And one of the big drivers of that was for improved quality. They are a 25-bed hospital. They do, a couple dozen cultures a day. They don't have the MALDI-TOF. They don't have microbiology directors. They don't have all the kind of the extra resources we have. And we were finding, patients who ended up being transferred from that hospital here to the main hospital having workup that was kind of conflicting with what we were getting here at the main hospital. So that was one of the ways we were able to approach kind of their medical leadership and be like, hey, this is, it's not like a huge volume on your part. You're relatively close. You can do this like we do for a kind of another sister hospital. But it is definitely a challenging process, even for a lab of that size, where it's not a huge volume hit to us at the main lab. But there's still a lot of moving pieces to get people on board, kind of up and down the chain. And then the other thing that always comes up, at least in our system, is what is the state of that affiliate microbiology laboratory, that affiliate hospital. We have hospitals that the health system owns. We have hospitals that the health system manages. We have hospitals that the health system is otherwise affiliated with. And that creates, layers and levels of challenges with pricing and contracting and all those fun things.
Okay, awesome. Do you have any comments also, Julie, or? Good, okay. So we have a question from Tam about QC. So how is QC for media, new lot, new shipment handled? Are the media plated with QC organisms locally and then sent to the central lab for incubation? Or are uninoculated plates sent to the central lab for plating and incubated? Or does the local lab handle their own QC? And we have a bunch of different health systems, so I'd love to hear how everyone handles this.
I'll start us off because I think this relates primarily to like a pre-plate and send type situation. But yes, we have all of the sites. They maintain their own. They maintain and perform their own QC for the media. As I mentioned, we have every single tote come with some dedicated QC organisms, so they definitely maintain their own stock of QC bugs. And then the way that I don't want to go into too many details and take up too much of the time, but to the simplified answer, yes, each site maintains their own media supply and QC approaches. But part of our SharePoint is we have like resources and guidelines that they can use to work up those. But it's largely each independent laboratory.
We have lab automation, so TLA, so everything gets sent here because we can't, like a pre-plate model wouldn't really work too well with lab automation. So
Our multiple locations also maintain their own QC.
Thanks, guys. So we have another question from Gerald. How do your locations, how do they handle biosafety questions, specifically with regard to high consequence pathogens that may ultimately be recovered from specimens plated at local labs? Who coordinates the response? Is it standardized?
Do you mind if I go? Sorry,
Go
this
for
just
it.
happened. This just happened to us. We had a Brucella exposure, and it is an interesting situation because it was a real phenomenon that's been published about where Brucella can actually stain as small gram-positive cocci, which I wasn't aware of until this occurred to us. But our sending site saw GPC. Think they did everything absolutely right with the gram staining. So our blood bench worked it up on the open bench, and we had exposures both at the sending site and our site. So we already had some of this material in terms of how to report and coordinate select agent reporting, especially because we do cross state lines. We have Montana as well as Washington, and we even have some folks who seek care in Southeast Washington from Oregon. So we already had before this exposure some of that material of like who, calling which health jurisdiction based on where the patient is from. But now after this and having, now there is we had additionally a Francisella that was from Montana that we worked up here, and then the CDC needed to coordinate with both of our sites. So we've now have formalized procedures for who needs to contact whom. A lot of work went into finding which, even a call list of who calls what. But this is definitely a scenario where there's nonstop coordination where the labs are calling and emailing each other, making sure everyone is CC'd on the same email thread to make sure that the right documentation of destruction of specimen and pathogens occur, and all the right folks in the right health jurisdictions have been notified.
We're very fortunate in that we are a large enough institution that we actually have an HCID unit at our hospital. So if a patient were to present with, some strange disease, we're not sure what it is. Maybe, we had that Ebola scare in the United States for a little while. We have a dedicated unit where we can actually put those patients, and we have a little laboratory right in that unit that allows our providers to do testing right there. Those specimens don't even have to leave the unit for things like biofire testing, those little multiplex PCR panels that happen quickly. And then we actually made separate test mnemonics for cultures, things like that were those high consequence infectious diseases, so that when they came into our lab, our staff immediately saw them and knew exactly what to do with them. We also are fortunate enough to have a BSL-3 on site, so we have a dedicated place where we can handle some of that stuff that some smaller laboratories cannot. For our more remote locations, we tend to have them work directly with our state health departments, so if they don't have to send them to us, they won't.
I'll say, so in addition to the hospitals that we do all the micro for, we are a referral laboratory for some testing for other hospitals in our health system. And so part of it is just being diligent and being aware of our, for our own staff, of always being skeptical of what we're receiving from the other hospitals and treating it as it could be something significant like a brucella or something like that. And then if and when we have concerns that come with organisms coming from other locations, to coordinate, let them know, but also coordinate and let the state handle, let our state public health handle a lot of the workup.
Awesome, thanks. So I have another question. When you're sending the plated specimens, do you also send the original specimen with it in cases of failure, or does the specimen stay at the originating lab? And I'm sure different places do it differently. Just maybe like, let's hear some things to consider and what your organizations do.
Sure. To start us off again, great question, and actually something that we changed in the middle. I already went over, but I had a slide about some of the changes we made sort of midstream or after go live. And one of them was about specimen management. So when we went live, and especially since the scale of pre-plating and sending was such an unknown, we wanted, and we had every single site send an aliquot of a specimen. Every single specimen that they would plate, they would also have an aliquot that they would send to us. And for critical specimens, they would save some on site for, send out testing, molecular type testing. And to us, that seemed like a safer approach. I will also say that when blood culture bottles go positive, they send the plates and they test the bottles with their in-house molecular panels, and they send the bottles to us, which I still maintain is a good approach because we need them more than they might. But we decided a couple of things factored into our decision to stop the practice of sending those aliquots. It's a lot of work to pour it off when you have low amounts of specimen. How do you divide, a few drops into even smaller numbers of drops? There were a few unfortunate cases where specimens got lost. We don't know where they went at the sending site. We couldn't find the aliquot that we thought came to us. So something that intended to go out for molecular sequencing was not even available. And then when, again, kind of thinking back to the model of like when something gets worked up to when it gets plated, if we wanted that specimen on hand to do any more gram staining or just like replating, well, why don't we just have them make a gram stain with the specimen there? Or why don't we just have them make another set of plates, reset it, and send it to us because we won't be able to read it the next day anyway. So we stopped that. Oh, and also it was super hard to keep track of all these specimens. We just ran out of storage space. So all of those have led to us just having each site keep all the specimens with the exception of blood culture bottles. And it's worked fine. Actually, we haven't had any of those losses or misses anymore. And so it's been a lot smoother process.
Does anybody else from the panel have any comments?
So we get the specimens, and for blood cultures we get both the bottle. The outer sites, they do their own gram stain, but we repeat the gram stain when we get it here, the bottle here. So
Okay.
Yeah, we are very similar in that.
Okay, so another question, where are the gram stains kept in a consolidated lab? Are they kept at the originating lab, or do they travel with the specimen? What quality program was used to provide feedback on incorrect gram stains? Do you repeat the gram stains? I think Kevin said that you repeat the bloods.
Mm-hmm. We do as well.
and we do the primary gram stain for everything else. So but yeah, I know it's definitely something where we have to feedback, and we'll feedback to the manager at the sending lab if there are if we find differences with the gram stain results, because the bugs do not always read the textbook, and sometimes they look a little, they aren't just the nice beautiful GPC and clusters, and so there's definitely been times where we've had to provide some context and feedback about the gram stain result.
Yeah, and there was actually a question in the chat that I was actually just typing an answer to on the same topic. We have the sites read gram stains for everything. Anything that requires a gram stain, the sites read it. It's definitely, there was historically at our sites a lot of micro expertise. Might change over time, but we're grateful it's still there. And when there are discrepancies, I noted that we have like our issue tracking log. So any discrepancies between what grows and what was originally reported, we request that they review those. There have been cases where we've asked them to send them to us so we can review and provide feedback. Largely, it works pretty well. There are some sites that felt like they were not able to keep up with gram stain competency as best they could. So we actually created, we haven't done this for everywhere, and we kind of maybe we'll trial it out in 2025, but we actually created like a training set where we just inoculated some tricky or bugs with tricky gram stains in blood bottles that were already, negative waste bottles. Like, so some painy bacilluses, some Clostridium, some of those gram positives that may underneath colorize or have a weird morphology. We inoculate those, make our own gram stain in-house, and then send the bottle to them and our pre-stained slide. And then at one of these sites, that the supervisor made a series of slides, stained them, and then kind of use that as kind of like a training set for folks that they needed. But they still are maintaining their own competency. So they participate in like CAP programs for gram staining to make sure that they're still competent. So it's both a mix of like qualitative day-by-day feedback on cultures that we document, some specific training evaluations that we're trying to do, and then also like, proficiency.
Okay, awesome. So we have a question from Tristan. How was proficiency testing changed, if at all, especially with those sites that played on site?
Sure. I'm not as well versed in the different specific proficiency categories, areas, or the CAP proficiency menu of things you can actually purchase. So I don't think I can speak as directly as I probably ought to. I'm fortunate enough to outsource a lot of those decisions to the sites. But actually, during some of that pro forma business model creation, one of the areas that we did call out as an, not a major rationale financially for doing this, but that the site's not needing to maintain some of that proficiency for all the downstream workflows, et cetera, was actually a win. And that really simple. Excuse me, I accidentally muted. That not needing to maintain that actually was kind of a win. So it did change. It definitely became a lot more narrow, but it did need to be more restricted to what work was actually happening at the sending sites.
Does anyone else have any more? Julie, I think you're talking. There you go.
Yeah, sorry, I was on mute. I've got my 2 dogs in here with me today, so I didn't want them to be noisy while I'm not talking. But our proficiency testing has actually been really standardized across our spoke sites as well as our central location. We're very fortunate in that we have a micro working group that meets in our little spoke locations that standardize really everything. They review their SOPs together, they plan their proficiency testing together so that they're giving sites and workers at each site very similar proficiency testing, very similar annual competencies, so that they can really assess from location to location how their labs are doing. And it's worked out very well.
Okay, great. I think maybe we have time for one more quick question. I know there's a question directed at Lorianne about what kind of different training did you do with your MLS students at the partnering training sites? So I don't know if you want to quickly answer that.
Yeah, so it was a challenge because so my program, although the Consolidated Micro is here in Spokane where my program is, we lost one of our other local sites. So that made a little bit of a compression for student rotations. And so for our students specifically, but also for the other students that were being supported by the other sites, we developed some Choose Your Adventure PowerPoints, kind of like the old Choose Your Adventure model books, as a way for them to access those cultures and organisms that they're no longer going to be able to see from, simply working up a positive blood culture, right? So mixed cultures, wound cultures, stools, that kind of thing. And that was a helpful way to support in kind of an online model so they could get access to lots of different things that they could see even if they're at a site that was reduced. But we try to be really creative with that, and there's ways that we've been able to work around our think critically about our clinical rotations, reevaluate how much time we need, reevaluate our checklists, so that we're meeting entry-level competency for all of our sites, even if they're not the main hub, and then simulation. So that's how we've kind of been able to maintain that. For sure, it's been a fun challenge, but it's been a challenge.
Awesome. Well, thank you so much to everyone on the panel, and thank you, Rich, for that excellent presentation. This is going to conclude today's program. A recording of today's events will be available within 1 week. Thank you so much. Have an awesome Friday and a great rest of your day.
Thanks, everybody.